Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do you... Who do you have? So, Alex, who do we have with us today?
Today we have two special guests who are joining us from the University of North Carolina at Chapel Hill. They're both in emergency medicine. We have Brooke Namboodri and we have Tim Platts-Mills. Welcome to the Jerry Pal Podcast, Brooke and Tim.
Hey, guys. Thanks so much for having us.
Thanks.
So we're going to be talking about your new article in the Journal of the American Geriatric Society, or JAGS, on elder abuse identification in the pre-hospital setting, an examination of state EMS protocols. But before we go into that, we always ask our guests if they have a song request for Alex.
Yeah, if you could play Old Man by Neil Young, that would really warm my heart. And my daughters would also appreciate that.
We're going to give it a try here. I'm just going to play a little snippet at the beginning, and the rest will be at the end of the podcast. Oh man, look at my life. 24 and there's so much more. Live alone in a paradise. It makes me think of two.
And you just learned that one this morning, didn't you?
I just learned that one in the last 10 minutes.
Alex actually had financial abuse committed to him.
I was the victim of abuse this morning. I got a call from a from a collection agency saying I would sprint $5,000. And fortunately, I had the means and wherewithal to call the police, track this down, go to the Sprint store, all before this podcast this morning. I actually got off the phone with the police because I said, I have to go to work. I did not say I have to go learn a song, get on a podcast. But
that's work.
You see, priorities.
Yeah,
right.
Priorities.
But other older adults do not have that. Many of them are victims of elder abuse of one form or another, including financial abuse, very common. And that's what we're going to talk with Brooke and Tim about today.
So maybe before we get into your JAGS paper that was just published, how did you both get interested in this subject of elder abuse?
I might try to take that on. So I've been interested in the care of older adults in the emergency department for about 8 or 9 years, and I mentored a woman named Tarshona Stevens about 6 years ago, and she wanted to do a project. We sort of decided we'd do a project on the non-medical problems faced by older adults, and we got a little bit of data on elder abuse as part of that. And we found that 7% of older adults in the emergency department reported elder abuse in the past year. And then my mentor, Sam McLean, who has a lot of funding has an R01 to look at persistent pain after sexual assault, met with somebody with NIJ named Carrie Mulford. I got connected to Carrie, and that led to both funding from NIJ. We submitted for a grant and received funding to develop an emergency department-based screener. And so now we're sort of in the space of elder abuse. It was a sort of a twisted route, but that's how it goes.
And when you think about elder abuse in the emergency, so how did you transition from thinking about elder abuse in the emergency department to thinking about it in the pre-hospital setting?
Yeah, great. So we saw that elder abuse was this pretty common condition that older adults are coming into the emergency department with. However, a lot of these emergency physicians are unable to see some of those observations that EMS providers can so readily see when they visit a patient in their home environment. They're able to see, how the condition is with their home. Are they taking, their empty medication bottles lying around? What are their interactions with their caregivers and this often unexpected medical condition that shows up? And so we kind of saw an opportunity with EMS providers to act as someone who can implement a screen in the pre-hospital setting in order to identify victims of elder abuse. And so we saw kind of a partnership between emergency providers and EMS providers as a great next step for identifying elder abuse.
And some of this, you make the point that we need, it's so helpful to have the eyes and ears in the homes of older adults who might pick up on elder abuse. But I think the other point you're making is that often they're not called in for the elder abuse itself. Is that right? And that this is incidentally either discovered by pre-hospital providers or reported in the emergency department, though it may not be the presenting issue at hand.
Right, exactly. A lot of these older adults are coming in for some, for a fall or some other condition, and then they're, like you said, they're incidentally finding elder abuse, that they've experienced elder abuse in some way, shape, or form. So we're hoping that EMS providers can fill that gap of being another kind of set of eyes and ears in, directly the patient home to validify if these patients have actually experienced elder abuse and what that abuse looks like for those patients.
Point I would make is that in contrast to child abuse or domestic violence, where a lot of times there are clinical findings that are pretty obvious that are causing the patient to come to the emergency department, like the patient has, a black eye, comes into the emergency department after getting hit by their boyfriend, let's say. That's not so hard to figure out. But in elder abuse, a lot of times it's not staring you right in the face. It's a little bit below the radar. It's still present. It's still really hard on the patient. It has a lot of consequences for health outcomes, but it's a little more subtle. And so, yeah, as you're saying, it's not necessarily the chief complaint that brings them in, but it's there for sure.
Do we have any data on how often it's actually picked up by EMS or by emergency medicine physicians?
So there's no data specifically about EMS providers. However, there's just there's a dearth of data in this area in general. However, we do know that about less than 5% of all cases are reported to the authority, whether that be from emergency provider or another kind of provider. It is about less than 5%, which is a pretty ghastly number.
And, just to pick up on this point about using pre-hospital EMS providers for this service, it's not actually what they were designed to do as far as I understand it. Like, they're the first responders for emergencies, but this is really asking them to fulfill a public health mission at the same time of screening the elderly population for elder abuse.
Yeah, that's a great point. And actually, EMS roles have begun to kind of develop into being some of these people that are able to go into people's homes and identify social problems like elder abuse. There's, a lot of these programs that people are naming community paramedicine programs where EMS are coming into homes and identifying social problems beyond elder abuse, so things like malnutrition, heating, and they're acting kind of in that social worker role. And, doing things like health preventative and checking up on patients who were discharged from the emergency department and need help with taking their medications and stuff. So we're hoping that as that role evolves, that, we can identify elder abuse as a really important next step in, to bring into that role for EMS providers.
Mm-hmm. I would add that like the mind of the emergency physician is gradually evolving on the issue of the role of the emergency department in public health, and I think we've come a long way. I think a more traditional view is like, hey, we just deal with the emergency issue, but of course, like we update people's tetanus, even though they don't have tetanus, so that's kind of a public health role. And, it turns out that, like, if you want to deal with the HIV epidemic, you should probably be screening for HIV in the emergency department because some of those high-risk people are only really contacting the ED. And so, like, there are places in which we see, like, in emergency medicine and in pre-hospital care, there are these public health roles that, frankly, like, you can't deal with those problems except by leveraging the opportunity of the emergency department visit.
And even more than that, actually, in studies that have surveyed EMS providers to kind of assess their willingness to do things like that, EMS providers overwhelmingly say that they not only identify some of these cases of elder abuse or social problems in the pre-hospital setting, but they really want to do something about it. So, like Tim was saying, this is a role that is evolving and something that I think EMS providers are really ready to take on.
So that kind of leads us to your study describing whether or not there are protocols relating to the identification, management, and reporting of elder abuse in EMS protocols. Do you want to tell us a little bit about what you did?
Right. So for the study, we examined publicly available statewide EMS protocols and other accompanying documents like system protocols, procedures, and guidelines. So we really tried to limit the search to documents that were specifically intended for and available to EMS providers. So we searched these documents via 3 different ways. There was an appendix of a paper that looked at EMS protocols. It was by Kupas, an author Kupas. And then We looked at emsprotocols.org and then also each state's public health website. So essentially, we went and looked at all 50 states and tried to find any publicly available EMS protocol that was out there. More specifically, these protocols are written mostly for BLS providers, which is the basic life support or advanced life support. And we were really willing to kind of take either of those, either document, because ultimately we didn't really care if it was the level of training that these EMS providers had, as long as they were able to identify elder abuse. And then after we were able to identify each of these protocols, we searched the protocols for terms like abuse, neglect, mistreatment, and looked for the associated qualifiers like elder, senior, geriatric, and then try to identify protocols that mentioned elder abuse, defined elder abuse, listed any indicators of elder abuse. So, things like bruises or fractures, those physical indicators, or psychosocial indicators like they're not making eye contact with their caregiver, or environmental indicators like the house is cluttered. And then we also looked to see if the protocol described patient management, if they were to identify a patient experiencing elder abuse, and finally, if the protocol mentioned that the elder abuse should be reported, and if it was mandatory in their state or not.
So, what did you find? Is it in many protocols?
Yes. So there are not all 50 states have statewide protocols for. So, for example, we're not going to talk a lot of trash about California because California doesn't have a statewide protocol. It has basically county-based protocols. So, but of the 35 states that do have protocols, only 14 mention elder abuse, and so you're less than half even have content in elder abuse. And then if you look in terms of like what do they provide? So 10 out of the 14, give a description of indicators. 8 out of 14 describe patient management. The majority of the ones that do, 12 out of 14, provide instructions for reporting. So it's the minority of states, among states which have statewide protocols, only like less than half, 40% have protocols which address elder abuse at all.
So on its surface, this is really concerning, and probably it is so. But a couple of caveats. One is, so a state like California, where the EMS providers tend to be regionalized rather than statewide, is that part of the reason that there is no statewide protocol in California, as opposed to a state like Oregon, where my understanding is they're able to have a pulsed registry in Oregon because they only have one EMS provider for the entire state?
So I think that how the EMS providers system works really just varies state by state based on laws. So I think ultimately it boils down to if the lawmakers decide that EMS protocols should be mandatory statewide and that every single county should have the same exact protocols, or if they want to give their counties a little more space to move around and make their own protocols, which was the case of California. This might be influenced by how many EMS providers or how large the state is and things of that nature. But it is mostly a regulatory issue with the EMS providers, and that's why it just varies so much state by state, region by region.
You notice how I came to the defense of California there?
Yeah.
Is that good?
Yeah, I see where you're going with it. Yeah.
So
I think at the end of the day, there are a lot of protocols out there that don't include elder abuse as a description, and that our findings are also consistent with when they've done interviews, qualitative work with paramedics and EMTs, and they say, hey, how do you feel about identifying elder abuse? They say we'd like to and we see it, but we just don't have any mechanism for describing it, and there's not a clear pathway for reporting it to providers, and the emergency providers will sometimes ignore us. And so I think there really is something that could be improved here.
do we have any, like, if you had to compare this to the child abuse, do we have any data on like is it similar as far as number of protocols that have information, like what EMS should do in those circumstances or what to look for?
Yeah, so this was something that we were really interested in it as well. And so we did a similar with a similar mechanism, we searched child abuse. We searched child abuse in protocols as well. And what we found is that twice as many protocols actually mentioned child abuse, and all those different metrics that we were talking about, defining elder abuse, finding indicators, instruction for management and reporting. There was about twice as many of those metrics found for protocols with regards to child abuse. We hypothesize that this is due to several reasons, one of which is that there's just a lot more research surrounding child abuse. So child abuse has just been one of those things that has been talked about a little more frequently for a little longer. And so it could have, it's been integrated into these EMS protocols just because it's kind of been out in the open for longer than elder abuse has. And we're hoping that we can kind of forge a similar path with elder abuse, that that the path was follow that pathway for child abuse with elder abuse, since the pathway has kind of been forged. That being said, we were shocked that not every protocol mentioned child abuse, right? So there are only 80% protocols that mention child abuse at all, and the fact that 20% of these protocols that we were able to find didn't mention child abuse, I think demonstrates that there's still a lack of fully understanding of abuse and how to identify it, and how to really leverage the role of EMS providers in identifying any kind of abuse in the pre-hospital setting.
Backing up a moment, I think we should talk about why are we talking about protocols? Like, why can't they just tell the EMS? Why can't the EMS providers just say, "Hey, guess what I saw in the home setting"? I think Tim, you alluded it to somewhat just a moment ago. Protocols are the structured way in which this information is transferred. But why this emphasis on protocols?
That's a good question. The truth is that if it's not in the protocol, it doesn't technically keep an EMS provider from doing it. And so there are states, for example, Idaho doesn't have a protocol. When we search, as of the time that we search, their state protocol doesn't talk about elder abuse, but there are certainly EMS providers who recognize elder abuse and tell EMS and the emergency physicians about it. It's not just like absolutely, if the protocol is there, it happens, and if the protocol is not there, it doesn't happen. However, the protocol really does support the activity, and EMS is a very protocol-driven system. So basically, the response to every paramedic or pre-hospital provider is just do what the protocol says. That's always the answer. And so if the protocol is there and it supports it, then it becomes sort of like a behavior that they can do, and it's clear what are the next steps and what additional information they should be collecting in the field. And then it's also better supported in terms of communicating with physicians. And I kind of mentioned this earlier, but like if you ask paramedics, they will say that they often feel obstructed in trying to report this information to emergency physicians. And it's not, the protocols don't completely solve that, but I think would solve that to some degree.
So, it sounds like there's a potential path forward looking at child abuse protocols, and that it sounds like EMS is not only willing but eager to actually have this as part of their job. What's the next step? Where do we go from here?
Well, our hope is that this article and the related work that's going on in the field of elder abuse will raise awareness by medical directors of EMS systems to change protocols. But it's a little heavy-handed to say, well, your protocol doesn't have it and we think it should, and so put it in there. Because the obvious response would be, well, what's the data that this is actually the right thing to do? Now, you and I might agree, like, well, it seems like the right thing to do. But if you look at the U.S. Preventative Services Task Force recommendations on elder abuse, like it doesn't even support screening for elder abuse basically in any setting or in primary care, which is really what it's focused on, because there's no data to support it. So there's really like the research field is really kind of a little bit behind in terms of developing what are the screening tools and instruments that we should be using in the pre-hospital setting, and then B, like what's the evidence that this is actually helping patient outcomes. So there's a lot of actual work to do. Now, I personally don't think we should wait for all that research to be done to go ahead and put those protocols in place and try to develop the capacity of pre-hospital providers to identify elder abuse. But unfortunately, there's still a lot more work to be done.
To add on to that, I think on a day-to-day basis, there's things that providers can do. And I think one of those things is really just to listen to what EMS providers come in and say to them. Even without the structured protocols or screenings in place, EMS providers are most likely identifying some of these things that we're hoping that they're identifying, like a cluttered house or those medication pills everywhere or a caregiver who's intoxicated. And making those mental notes is really important and something that if they just are able to communicate to the ED providers would be really big and can kind of, I guess, if you facilitate that conversation and that exchange of information, you start to get another layer of providers looking at elder abuse and, is this person possibly experiencing that? So I think opening that line of communication is something that on a day-to-day basis, ED providers can do to start to identify this elder abuse more and more.
Are emergency providers mandatory reporters of elder abuse if they hear about such concerns from pre-hospital EMS providers?
In every state except New York, New York does not have mandatory reporting, but all other states, yes. So any medical personnel who is in a position who gets that information is a mandatory reporter. The actual definition of elder abuse in most states is somewhat restrictive. So it has to, basically in North Carolina, in order to be elder abuse, the person has to be dependent on other people. So for example, if my mom and my dad weren't getting along very well and they fought, it wouldn't count as elder abuse because neither of them are dependent. I mean, in any formal sense, they may be psychologically dependent on each other in a nice way, but they're not they're not dependent on each other. And so that would be domestic violence and that wouldn't fall under mandatory reporting. But if somebody's dependent, like they have difficulty walking, they can't meet their basic needs, or they have cognitive impairment, and there's abuse, then there is mandatory reporting, except in New York.
So if something like what happened to Alex this morning, somebody steals your Social Security number, charges $5,000 to Sprint, happens to an older adult in North Carolina, that's not considered elder abuse, is that right? Because it's not a dependent relationship.
If Alex was 70 years old but kind of did everything he normally does, then no, it probably technically wouldn't be elder abuse. It might be a crime, but it wouldn't fall under that.
Now, if one of his children or someone who's taking care of him had done that, then it would most likely fall under elder abuse.
So you're saying if it was his co-host on a podcast who bought a bunch of iPhones?
You stole $5,000.
I just want to make sure. Hypothetically.
Yeah, I came in and I said that to Eric, and he said, "Oh, hey, I just got 5 new iPhone X's from Sprint at my house." Great.
So I got a last question. So we've talked a lot about screening and the potential use for screening. And Tim, you also mentioned that there's not a lot of great research out there on really effective screening tools. What do you guys recommend as far as potential screening tools for elder abuse?
Well, there is the ED Senior Aid tool, which is submitted for publication as just described by our group. So I'm being a little bit funny because that is work that we're working on. But I think let me, rather than answer with that, let me say more broadly. I think in the emergency department, a couple principles apply. One is you really need to screen everybody, because if you just think, I'm going to get the people who have bruises on their arms, you're just going to miss almost everybody. The prevalence of elder abuse in the population is like 10% amongst older adults. So it's really common. So we should be screening, I think, universally. How you do that best is not entirely clear, but it's probably going to be some combination of a cognitive assessment, a really limited number of questions, because you just can't do a big battery of questions for every older adult who comes in the ED. They're not going to tolerate it, and the nurses or whoever's doing it won't do it. So it needs to be really efficient and limited, and then it needs to be more expansive for people for whom there are red flags. So if the patient has cognitive impairment or answers yes or refuses to answer a question, then you need to take a deeper dive. And we've tried our screen on 250 people, and we found like 17 cases, and that was among consenting older adults. So we think, for methodologic reasons, we had to get consent. So I think that's an underestimate of that gave us a prevalence of around 7%. Yeah, I think it's the exact tool is sort of up in the air, but and there are a couple published versions that none of which we think are optimal for the emergency department, but we think it's definitely something that that's a nut that we can crack, and we can come up with a good tool for the emergency department.
And to translate the tool that Tim is talking about to the pre-hospital setting, we're really hoping that it becomes a more observation-based as well. So as we were talking about, I think something unique about the EMS provider role is that they are actually going into these patients' houses and they're able to see the actual condition these patients are living in. And so building in some of these observations into that screening tool is another really valuable part of the screen that we would like to add in.
Mm-hmm. Eric, if I could add one other thing, I would like to add thanks to the National Institute of Justice for the support of and funding of our work to develop a screening tool. They didn't fund this particular project per se, but they have supported the senior aids tool. And the people at NIJ this work, we're not speaking on behalf of the NIJ in any means. They are funding this, the work that we're doing. And I'd also like to thank some of the collaborators on the project, including Cheryl Zimmerman and Bryce Reeve, who both have been extremely helpful.
Great. Are there any other things that you guys would like to talk about this paper, or anything else that we should before we close?
No, I think I would just echo. I mean, we're emergency physicians, but I see us as having kind of strong partnerships with the geriatricians, and we're thankful for that. And I think, Brooke mentioned it's important for emergency physicians to be sort of listening and open to comments from from the pre-hospital providers. And I think the geriatricians, likewise, there are parallels there in the inpatient setting for like listening to nurses who pick up on stuff. I mean, I think elder abuse is really something that takes a village to solve. And so it's important for us to be good village members and good listeners and consider it a team approach. And in some cases, in our system, we've had geriatricians help solve cases for us where we didn't really pick it up, and then they get admitted, and then we find out, oh, there are a bunch of patients from a nursing home, and they all had the same problem. The geriatricians are the one who figured it out. So it's very much a two-way street between emergency physicians and geriatricians in that regard.
Wonderful. Well, with that, we'll maybe do a little bit more of a closing with Alex singing more of Neil Young. But before we do that, just want to say thank you for joining us on this podcast. It was great talking about this.
Thank you so much. This is a very important issue, and I learned quite a bit about the role of EMS providers in public health and in screening for elder abuse in particular. Thank you so much.
Thanks so much for having us.
Thanks.
Love lost such a cost. Give me things that don't get lost. Like a coin that won't get tossed, rolling home to you. Oh man, take a look at my life. I'm alive like you. I need someone to love me the whole day through. Look in my eyes and you can tell that's true.
Thanks everybody for listening to our Jerry Powell podcast. Stay tuned next week for our next podcast.